Excuse me. Yeah, without any further delay, let's start with next speaker, that is Dr. Nandan Kumar, regarding the topic challenges and solutions of prehab before rotator cuff surgery. Okay, so Dr. Nandan Kumar, with an experience of 20 years in physiotherapy, he is a HOD of physiotherapy department at Rajashekhar Multi-Specialty Hospital and also holds post of quality head and accreditation. Dr. Nandan Kumar is the executive president of Bangalore Physiotherapy Network. We welcome you, sir.
Good afternoon. Good afternoon. I'm sure everybody has had a heavy lunch and I couldn't get a reply back. That's why. Thank you very much for Manipal Hospital and the organizing team for giving me an opportunity to talk about challenges and solutions of prehab before rotator cuff surgery. So we've been talking a lot of shoulder and shoulder related issues. So I'm not going to spend too much time about what is rotator cuff tear. Most of you are aware of what is rotator cuff tear and how to go about managing it. So I'm going to restrict my topic only to the challenges which we have before a rotator cuff surgery. So as we all know, the incidence of rotator cuff injury generally increases with age. It is generally seen, higher incidence is seen in the older age group. Males are more affected, generally between the age of 60 to 70. Earlier also, above 70 years, the incidence of male is to female ratio is more or less the same. And we should also remember, not all rotator cuff tears will be symptomatic. There could be asymptomatic tears also. And we also know that people who do more overhead activities are more prone for rotator cuff injuries. Now, reasons for RC injuries. Adult patient has a trauma, falls from a bike or falls from a two-wheeler, or he's traveling in a bus with his hand up and then suddenly there's a jerk, and these are one of the reasons. Sports trauma, very common to have rotator cuff injury, especially people who do a lot of bowling action and rotational forces. And elderly patients who have already an established degenerative tear or an established degenerative rotator cuff, and there may be a trauma which could lead to a tear. So now, coming to the challenges. See, when you have a patient with a rotator cuff tear, there is three options. Patient is posted for surgery, so your work is more or less easy. You just make a rehabilitation program before surgery, and you decide on what needs to be done after surgery. Where the challenge comes is when the patient says that, okay, let me think, do I need to undergo a surgery? It's better, I can manage with my pain. Can I manage? They are the borderline people, or people who refuse to undergo rotator cuff surgery. They know that they can't lift their hand, because we are dealing with elderly people. So they know that they can't lift their hand, and what will happen if I don't get operated? Or people who are thinking on the fence or sitting on the fence whether to get the surgery or not. This is where our challenges come. So what are the psychological factors which affect decisions of undergoing some surgery? One, we all know the uncertainty over the outcome of physiotherapy, outcome of the surgery, sorry. So there is definitely going to be a lot of emotional stress, because family support should be there, and the patient also has to decide about physiotherapy for post-operative care, financial planning. Obviously, the surgery is pretty expensive, and not only surgery but the post-surgical rehabilitation And if they have to undergo sports rehabilitation under Dr. Padmanabhan, then it will be pretty much expensive. So changes in lifestyle, yes, you're going to have a patient who is going to be in a sling for about 6 weeks, and in between you will have to, they have to manage their day-to-day activities with the sling, and then they will have to also undergo physiotherapy sessions during that time. So these do affect, a person undergoing surgery. So some of the general pre-surgery challenges, obviously there is going to be a lot of restriction in his range of motion. There is going to be discomfort in his activities of daily living. Pain, especially night pain. Patients who have a full thickness or a partial width or a partial thickness tear will be having considerable amount of night pain. And obviously there is going to be a loss of muscle strength and movement control, and also associated comorbidities. As we said, the incidence of some of the degenerative tear are in elderly people. They would have had diabetes, hypertension, and elderly people, and general constitution of the person. If he is fit, much easier for him to recover, and he will be willing for surgery. A fragile patient, a poor built patient, metabolically very poor in his health, these kind of people will pose a little challenge before surgery. So when patient is deciding for a surgery, what should be our role? See, we should be, as a physiotherapist, be able to explain about the outcome of not having a surgery. Most of the time patients may think that, okay, can I live with this pain for long? I mean, can I manage without surgery? It comes to a time. So pseudoparesis is one of the commonest thing which can see in rotator cuff tear. So what I mean to say by pseudoparesis is patient will have about 50 degrees of flexion and about 50 to 60 degrees of abduction. Basically it's his deltoid, and he will be actually hiking his shoulder, and it gives the true picture of a neurological deficit rather than a musculoskeletal deficit. Obviously there will be considerable amount of ADL restriction. And you should also look at the possibility of glenohumeral osteoarthritis, and you should also tell the patient that probably if he does not undergo surgery, there may be a possibility that he may have to go for a more complicated surgery in the near future. Especially a patient with a rotator cuff tear could eventually have a glenohumeral osteoarthritis and may require a reverse total shoulder replacement, which is a much more complex and a longer rehabilitation and a much more expensive surgery than undergoing a arthroscopic rotator cuff repair or an open repair. So you should also be setting his goals of rehab post-surgery. So challenges, preoperative stiffness. Yes, preoperative stiffness is common in patients who undergo rotator cuff surgery. And if the restriction of the total range of motion is less than 50 degrees, they generally improve with surgery. What I mean to say is the total range of motion is you see how much is the deficit of his flexion, abduction elevation, external internal rotation. You add how much is the deficit, and if it is less than 50 degrees, generally after rotator cuff surgery they improve. But if the total deficit, I'm talking about deficit, is 70 degrees or more, then you should also consider that there is a possibility of adhesive capsulitis, and he may require a side-by-side procedure of even probably a capsular release after during his surgery of rotator cuff. So solutions, what do? Improve glenohumeral range of motion. I'm not going to give you the exercises what is necessary to be done. Our Raj Kannan and who is going to talk later on, and Padmanabhan and Sumit, who did the first workshop, have all given us a lot of techniques of how to mobilize the shoulder, how to improve glenohumeral range of motion, how to improve scapulothoracic range of motion, how to improve upper back and thoracic spine range of motion, and encourage movements in the functional pattern. So always try to improve movements in functional pattern, and consider improving of night pain. Therapeutic modalities, for whatever it is worth, give them a try. Scapular stability exercises, yes, they will require such things to improve night pain. And train and identify the comfort posture for sleep. So you need to see, especially night pains are very common in partial thickness tear of rotator cuff. So you need to identify how do you find comfort movement patterns. So suggested intervention, passive and active range of motion exercises, neuromuscular control exercises, and Padmanabhan has given a brief about it. Deltoid strengthening, specifically anterior deltoid strengthening, because it helps in kind of, some studies have suggested that strengthening the anterior deltoid helps in centering the, the humerus to the glenoid, scapular stabilization and training, and also don't neglect the bigger muscles, the trapezius, biceps, triceps, levator scapula, latissimus dorsi, rhomboids, pecs, serratus anterior, and etc. So, what is the outcome of your prehab? What do you want to achieve? So, pain management, improve strength, improve control, reduce the duration of your post-surgical rehab. So, this should be your goal of identifying your outcome of prehabilitation. Now, who responds poorly to physiotherapy? These kind of patients generally don't do well. If there is already an established glenohumeral OA, type 2 and type 3 acromion is already seen, decreased passive range of motion, and there is already a radiological establishment of superior migration of the head of the humerus, and at the same time you have a weak external rotator, and on MRI scans you see that there is already fatty infiltration of and muscle atrophy in the supraspinatus tendon. Generally they do poor to physiotherapy. I'll be finishing in a minute. And generally who respond well for physiotherapy has good forward flexion of more than 90 degrees, no radiological superior migration of the head of humerus, pain scale around 4 out of 10, type 1 acromion, fair to normal external rotation strength, and no evidence of muscle atrophy. Generally they respond very well. I'm just going to show a video of one of the patient who had to undergo surgery, and this was his abduction range. You can look at his face, he's wincing in pain. That is what he could do. And this was his flexion range, and with the assistant you could just barely manage to get, but his passive range of motion was pretty good. He goes all the way to about 120 degrees. So we took him for physio and rehab, and this is what we achieved. We got him reasonable amount of forward flexion and reasonable amount of abduction. You see still his shoulder hikes a little bit because obviously there is no rotator cuff, but he is able to maintain it. So what I mean to say, stick to your rehab program and see how well you can get your patients to do a good rehab program before surgery, and then post-surgery follow up with them. So thank you, some references, and if you have any questions, I think we will discuss it during the panel discussion.
Thank you so much for the talk, sir. Next, I would like to call upon Dr. Nabil on the topic fascia and shoulder pain. Dr. Nabil is a MBT, did his MBT in musculoskeletal disorder and sports injuries, currently working at NAM Rehab. Also worked as a physiotherapist at Sakra World Hospital, senior physiotherapist for Telangana Kabaddi Premier League. He also worked as qualified physiotherapist at CSI Mission Hospital, Kodakal. We welcome you, sir.
Good afternoon, everybody. Thank you, Benjamin. I would like to thank Manipal and especially Dr. Ayyappan for giving me this opportunity. I'm going to quickly browse through this topic and just discuss through the basics. As we are short on time, how much time do we have? 10 minutes. I'll finish it in 5. Is that okay? Yeah. Okay, that's the best thing of riding in Bangalore. You can reach everywhere on time, or you learn to finish it on time. Okay. So fascia, as you all know, it's a thin casing of connective tissue that surrounds and holds every organ, blood vessel, bone, nerve fiber, and muscles in place. The tissue does not just provide the internal structure, but also has a nerve supply, which also makes it feels like a skin. It's as sensitive as skin. So when stressed, it tightens up. Why so serious? Relax. Don't let your fascia tighten up. So, although fascia looks like one sheet of tissue, it's actually made up of multiple layers, and it has a fluid in between called hyaluron, and it is designed to stretch as you move. So the more you move, the better for the fascia. So there are other certain things which cause fascia to thicken and become sticky. So it dries up and tightens around the muscles. It can limit mobility and cause painful knots or triggers. So these are the shoulder fascias. I'll quickly run through it. Deltoid fascia, subscapular fascia, supraspinatus fascia, infraspinatus fascia, pectoral fascia, axillary and clavipectoral. Coming to the deltoid fascia. Now, deltoid fascia is a fibrous membrane surrounding the deltoid muscle, and it covers the muscle on the outside. Unifies with the pectoral fascia frontally and attached to the clavicle, acromion, and crest of the scapular spine superiorly. Then it continues with the brachial fascia and into the arm inferiorly. At the back, it is continuous with the strong posterior infraspinatus fascia. Then comes the subscapular fascia. So it covers the subscapular muscle, as the name suggests, attaches to the anterior aspect of the scapula and insert into the lesser tubercle of the humerus. Now the action is protection of the scapula. So overlying fascia is relatively thin and aponeurosis and attached to the entire circumference of the subscapular fossa. So the deepest surface of the fascia gives rise to some superficial fibers of the subscapularis. Supraspinatus fascia. It covers the supraspinatus and dense structure and completes the osseo-fibrous compartment in which supraspinatus is attached. It is thick medially, as you can see, and thinner laterally under the coracoacromial ligament. It is attached to the scapula around the outer circumference of the attachment of the supraspinatus. Coming to the infraspinatus fascia. So it's attached at the edge of the infraspinatus fossa and continues anteriorly with the deltoid fossa. Overlaps the posterior border of the deltoid muscle as well. So the pectoral fascia, it's a thin layer, covers pectoralis major and extends between the fasciculi. So medially attached to the sternum, as you can see, and superiorly attached to the clavicle. So infralaterally it continues with the fascia of the thorax, shoulder and axilla. So it's thinner over the pectoralis major and thicker in between the pectoral major and latissimus dorsi. So laterally it forms the floor of the axilla and is continuous as the axillary fascia. And there you have the axillary fascia. So it's relatively dense, special at the central third of the shoulder and below the deltoid muscles. So it divides into two at the lateral margin of the latissimus dorsi and it covers the muscle. Attached posteriorly to the spinous process of the thoracic vertebra. So this crosses the axilla and splits into envelop the pectoralis major as well. At the upper edge of the pectoralis minor, it becomes the clavipectoral fascia. So that's the clavipectoral fascia. As you can see, it's a strong fibrous sheet and posterior to clavicular part of the pectoralis major. So it fills the gap in between the pectoralis minor and subclavius, covers the axillary nerves and vessels. So it also splits around the subclavius and is attached to the clavicle both anteriorly and posteriorly to the groove for the subclavius. So fascia related muscle pain and stiffness. Now any healthy fascia, you know that it is smooth and you feel the movement is fine, and anybody comes with less flexibility, you may, as a physiotherapist, may suspect fascia involvement also, not just your joints and muscles. Okay, so when the fascia becomes crinkled up or crinkled or tight, then you can get adhesions. So what are the usual causes for adhesions? Like what earlier my previous boss said, Padmanabhan sir said, no mobility, poor mobility, or limited physical activity. I guess physiotherapists are the best people in that sector, right? And repeated movement and trauma or any post surgery. So how do you classify, how do you understand whether it is a fascia pain or a joint pain or a muscular pain? Anybody? Okay, so any muscular injuries or joint injuries, usually the patient comes with a symptom saying that I have pain during my movement, correct? In case of fascia, the pain reduces post movement, so they feel better when you give more movement. Anybody has anything against that? So any muscle injury or bone injury, you move that, you get pain. But fascia, when you move more, it reduces the pain. So remember that in your mind. So fascia adhesions feel better with movement. So it responds positive to your heat therapy and thereby increasing the tissue's elasticity, etc. So adhesions can worsen over time, causing the fascia to compress and contour the muscles it surrounds, causing trigger points. And I'm sure you're all aware about trigger points. So keeping the fascia flexible is the key. So move more, stretch, and focus on the posture correction. What about relieving the fascia pain? You have various strategies and you're all experts in that. Now you're not any basic physios, you're all masters in your field. And I'm sure you have multiple therapies, a lot, aquatherapy, dry needling, and a number of strategies you can use, okay? And include movement into that, remember that. Couple of evidences and articles based on that. And my references. Thank you. Am I on time? Yeah? Do I get an award for that?
Thank you so much for the talk, sir. You took Nama Metro instead of roadways. Thank you for that. All right. Next, I'd like to call upon Dr. Raj Kannan for the topic, frozen shoulder enhancing outcomes. And Dr. Raj Kannan is physiotherapist and musculoskeletal pain specialist, HOD of physiotherapy at RMV Hospital, Bangalore. He's a director at Apter Institute and Apter Healthcare Center. He has 20 years of experience in treating chronic spine pain. He's a clinician, course instructor, YouTuber, blogger, and researcher. And coming to his achievements, he has the highest Google ratings in physiotherapy services in North Bangalore. All right, you're welcome, sir.
Good afternoon, one and all. How many of you have had difficulty in treating frozen shoulders? Patients? Is it a cakewalk, treating patients with frozen shoulder? Difficult, isn't it? So whatever you achieve, next day they come, again it will be the same. So it's not easy to treat patients with frozen shoulder. So my talk here is about that, how to enhance the outcomes of the frozen shoulder. Before I introduce the concepts of my treatment, first see this video. He's a 28-year-old man. You could see his shoulder is shrugging as he's doing the movement. And the movement is not restricted only in abduction, it's also restricted in flexion, it's restricted even in internal rotation. So you know that it's a multiplanar movement restriction. And internal rotation and external rotation both are affected. And obviously you could see that even the passive range of motion would be affected for him. Okay, so looking at these clinical clusters, one can easily say that yeah, it looks like a frozen shoulder, isn't it? Because frozen shoulder people will move like that. So keep this video in your mind. At the end of my talk, I'll get back to the video. In the year 1934, Codman described it as a condition which is difficult to diagnose, difficult to treat, difficult to even explain. And now here, 2024, standing in front of you, the things really did not change much. Still, it's an enigmatic condition that most of the doctors and physios are struggling with. But we know certain things about frozen shoulder for sure, like the restriction of both AROM, restriction of range of motion is equal on both AROM and PROM. Agree? Disagree? Agree. Okay. And in these conditions, the X-ray will be normal. Means you would have ruled out arthritis of the shoulder, you would have ruled out rheumatoid arthritis, you would have ruled out calcific tendinitis or any other sinister pathologies like osteosarcomas or something, or fractures, something like that. So X-ray will be essentially normal, and still the AROM and PROM will be restricted. That is sufficient to diagnose most of the frozen shoulders. But still, there are so many questions to be answered. Why females are more having frozen shoulder than the men? We don't know. But I have a reason, I will tell in the next slide. Why diabetics are more commonly having the frozen shoulder? Maybe diabetes is a metabolic problem, frozen shoulder is also a metabolic problem, you can explain like that. Why it is affecting the non-dominant side? Because the non-dominant side ligaments, the capsules will be somewhat tighter than the dominant side, because dominant side we keep moving much than the non-dominant side. What triggers it? We don't know. Autoimmune, autoinflammatory. Why only frozen shoulder? Why not frozen wrist, frozen ankle, frozen elbow? It's very unique because of the capsule morphology is completely unique for the shoulder, especially the inferior fold what you have, axillary recess, so that could be the reason. Why not affecting the same shoulder again? We don't know the reason. So these are the unanswered questions that we are yet to answer. But there are some theories that are explainable reasonably well. If the theory of evolution is right, we are from monkeys. We are supposed to be always on the trees hanging around. So you see the monkey, how many number of times the monkey elevate the shoulder over it. And in fact, the mode of locomotion for the monkey is the shoulders, wherein we as a human beings have become more sedentary in terms of the shoulder. Sedentary in terms of shoulder means, okay, how many times you did today? You did 180 degree of shoulder flexion. Can you tell? Hardly. Maybe when taking bath, that's all. Okay, how many times? But a monkey would have been doing it for every fifth minute. The monkey will be doing that. So we have the comfort of the mixies and grinders, and then the laptops. Ladies are also working in front of the computer. So hardly anybody are doing the shoulder movement overhead. That could be the reason. So what I do as one of the treatment. So if that is the case, occasionally we have to become like monkeys. You need to hang every now and then. So one best advice I give all my patients who are having diabetes, who are above 40 years, who have the vulnerability to get frozen shoulder, man, hang every day. Okay. At least there is serious reduction in the risk of you developing the frozen shoulder. Even if you get the frozen shoulder, you won't get so severe because you are hanging every day. In other words, you hang, or if you are good in pull-ups, you can do the pull-ups as well. So this is the normal capsule from the cadaveric video. This is how the real capsule looks like. You see how thin and pliable, and it will be having almost like 10 to 12 ml of fluid inside that. That is a normal capsule. But in frozen shoulder, it is this capsule will get shrinked, fibrotic contracture, which reduces the joint volume. Thereby, the movement would be grossly restricted. So what we definitely know about frozen shoulder is based on all these evidences from arthroscopic studies and histopathological studies and biopsies and MRIs, all tell the clear pathophysiology of frozen shoulder, which is there is a inflammation happening in the capsule. Okay, there is a synovial hyperplasia, angiogenesis and neurogenesis of the capsule. What is angiogenesis? New blood vessel growth, new nerve growth. Whenever there is a new blood vessel growth and nerve growth, suddenly things will become sensitive. That pain. Now, are you aware of the frozen shoulder pain? That suddenly they do, and then they almost like sometimes collapse on the floor, and the tears will be in their eyes. That kind of pain. Somebody said that the frozen shoulder pain is as good as the pregnancy pain. Not all time in the day, but during that sudden shock pain they get, suddenly they do something and then they get the shock pain. We call that as a jerk pain. So that is the characteristics of the pain of the frozen shoulder. It's because of these pathophysiology of joint volume reduction, fibroblastic contracture and so on. And finally all these things lead to pain, joint stiffness, disability and dysfunction. So this much we are clear. We don't have to debate about that. The pathophysiology is clear, and these are the arthroscopic pictures of how frozen shoulder look like in the arthroscopic images. You see the red color capsule. It should be white. It should be clear. It should be pliable. Whereas if you see in the frozen shoulder, it is so red. It's because of new blood vessel growth. Whenever blood vessels grows, nerves will grow along with blood vessels. That's why we call it as neurovascular. Without nerves, there is no blood vessels. Without blood, there is no nerves. So it is so thick, and it's so, the capsule when it gets thick, fibrotic contracture, it's so tough to break. That's why you can't just loosen it immediately at your will. It's so stiff that it literally needs almost like entire body weight. This is my patient with frozen shoulder. I'm just moving his shoulder. His entire body is rolling towards his shoulder. So it is the power of the contractured fibrotic thick capsule in frozen shoulder. Jeremy Lewis once quoted that it needs 683 kg per centimeter square force to break the fibrotic capsule in frozen shoulder. So you think how much it is difficult to release the capsule, and what you have to do as a physio to break that kind of stiffness. You need literally a scalpel and the knife to break it, isn't it? But still, there's a method. I will tell that. Before that, you just see this video. This lady who came to me with a night pain. She's a pre-diabetic, obviously. Again, then she came to me and then I asked her to do the shoulder movement. Shoulder movement abduction is pretty clear. Good to rule out frozen shoulder, but wait, there is one more method, one more test you have to do. You just see here, internal rotation in prone lying. Okay, now this is a frozen shoulder. It doesn't look as a frozen shoulder in overhead abduction in standing. These are all freezing stage of frozen shoulder. Have you ever picked up the freezing stage of frozen shoulder? You have to pick up. Okay. No, even the doctor, orthopedician will miss this in his office because he will just ask the patient to do the movement. Maybe it's all looking well. Okay, there is no frozen shoulder. It could be a muscle strain. Take the tablet, go away. After 1 month, patient will get a frozen shoulder. Second stage, because most of the frozen shoulders are missed. Not most, I would say almost 95% of the frozen shoulders are frozen shoulder because they were missed and ill treated or not treated during the freezing stage. Okay, so if these frozen shoulders are picked up in the early stage, man, it's very, very easy for the patients as well as for the therapist. Okay, if it is not, then it became a problem for both of us. So average time that the patient takes to go to a doctor. Now, when you have a shoulder pain, would you go to a doctor? You don't. You wait and watch. You put hot pack, you put cold pack, you do YouTube exercise. You ask your relatives and what to do. You ask your relative friend. He will give you some medicine, and you try every bit of possible thing to delay your visit to the hospital, so that most of the frozen shoulder patients, they don't get diagnosed. Average time is at least three months. Okay. Now coming to the pain mechanism, so what I say is the tip I gave you today is what? You know how to pick up the early frozen shoulder? Prone lying, internal rotation. Do that, you know the early freezing stage of frozen shoulder, and that time only you start moving the shoulder. At least they won't go to the full-fledged development of frozen shoulder. Coming to the pain mechanism, if you are calling yourself as a pain physiotherapist or pain specialist or pain expert, get to know the neuropathophysiology of pain in every MSK condition. Because without knowing this neuropathophysiciology, whatever pain treatment you do, it will be like, you know, throwing the dart by closing your eyes. Okay. Now coming to the frozen shoulder pain mechanism, frozen shoulder is a problem with the capsule. The capsule is innervated by C5 nerve root. C5 nerve root via suprascapular nerve and axillary nerve, which has the pain referral zone over the arm. Okay, your frozen shoulder patients, you ask them where is the pain, they say the pain is here. Okay, would they say, doctor, my capsule is tight, it's here, it's paining? They will never. They don't know what is even the capsule. Okay, the brain does not have a dedicated area for the capsule to the brain, like your AC joint. Okay, so the capsule has to express its problem through some other area, so obviously the pain will be over here. So the pain mechanism is frozen shoulder is a referral pain. From the capsule, it's using the C5 nerve, C5 area is here, and that's what the physios will be doing, IFT machine, ultrasound machine, and then hard pack over the area. Even the patients will say, hey, give the machine here, no, it's paining here. Because patient want the treatment where it is paining, he will not know that it's a referred pain. Okay, referred pain and radicular pain are the curse for the patients and the doctors. We all deceive ourselves that problem is here. It's something like a sciatica, the nerve will be compressed in the back, the pain will be in the calf, patient will be doing calf stretching, or putting hard pack in the calf area, or dry needling in the calf area, thinking it's a calf problem. So the radiating pain and the referred pain is always deceptive and deceiving, so don't put goal for yourselves. Okay, it's a self goal. All right. Even the massage people do the massage over there. So for frozen shoulder, for every pain condition, there's a pain generator. The pain generator means the sole structure which is responsible for producing pain is called as pain generator. In frozen shoulder, it is the inflamed thick fibrotic capsule, and the pain referring area is in the arm. So who will meet you? The patients who are having stiffness will meet you? Never. Now, as I said, our Indians, they will wait till the last stage, and then they come to the doctor. So it's not the stiffness that helps them to meet the doctor, is the pain. Night pain. They will not be able to sleep in the night. That's the most important reason why people come to the physiotherapist or even the doctor. This patient waited for 6 months. At some point, he could not sleep at all. Then he met the doctor. By the time 6 months, stiffness developed. Okay. So frozen shoulder, now you tell me, is it a AROM problem or PROM problem? Frozen shoulder is an active range of motion problem or passive range of motion problem? It's a PROM problem. So, is the AROM is better than PROM? PROM is, when the PROM itself is not there, where is the AROM? When the PROM is not there, there is no AROM. So do understand, passive and frozen shoulder, it's a PROM problem. Only if the PROM improves, AROM improves. Only if the passive range improves, active improves. Let's say there's a condition called myositis ossificans. It's a PROM problem. No matter how much of bicep strength you have, doesn't matter. It's calcified, that's all. Joint is locked. So it's a first PROM, and then think about ARM, strength, stability, and those things. When it comes to frozen shoulder, the PRM should be improved. No amount of strength training will improve the PROM, and focus on PROM. So that's my essence of the talk today. So in that case, pain and reduced range of motion in frozen shoulder, it's not a myofascial stiffness, it's not a neural tightness, it's not a trigger point, it's not a joint stiffness, it's not a muscle guarding. If you think so, you are flawed, you are flying. It's not. It's a capsular ligamentous inflammatory stiffness. What is the proof? Here is my patient. He came to me with frozen shoulder. He had to go to USA in next 4 months. So he wanted quick result. He went to I referred him to orthopedic surgeon. He went ACR, arthroscopic capsular release, and you see the improvement in 1 week time after surgery. You see the range? Just arthroscopic capsular release, no physiotherapy. Okay, so that's the power of arthroscopic capsular release. I'm not saying everybody needs it, but some people need it. Okay. Maybe about 10% of all frozen shoulders, they probably need it. So you see how much the range is improved after the capsular release. So that's an indication that frozen shoulder is a capsular problem. If you think it's muscle problem, it is not. It's a capsular. Okay. And if it's a capsular problem, capsule is 360 degree, isn't it? Capsule is not only in anterior or posterior. It's a 360 degree capsule. It will be toughened or fibrotized in every possible area. Sometimes some people will have superior capsule more tight, some will have anterior, some will have anterior inferior, posterior superior. So different people will have stiffness at different areas of the capsule. That makes somebody will be more having flexion, somebody will be having more abduction. Some will do IR, some will not do ER. Some will do ER, some will not do IR. Like that. So many variations are there, but everything is all ultimately the capsule only. That's why the surgeon will be doing sometimes circumferential capsular release, because they'll be releasing capsule at every aspect, every circumference. So taking a leaf out of it, what if the physio can do the same thing but with manual methods? Okay, so that's what after protocol is, which we found to be very, very useful for this kind of frozen shoulder. We engage the capsule at 360 degree. See, when the patient is doing this movement, you can try this, but it's not only one direction, it's multiple directions. Suddenly they have to adjust the sari here. This is one direction. Okay. Suddenly they have to reach the car back seat. That's one direction. So we have to address every direction for the frozen shoulder. So we engage the capsule in every possible movement, direction, long lever, short lever, by giving end range overpressure. What is end range overpressure? Let's say I take the joint to the end range, I push further. Let's say the patient is having 70 degree or 120 degree range. From 120, I push another 5. Which patient, all patients will be able to tolerate. So that movement I do multiple times, like 10 to 15 times, and I do every day. So gentle overpressure applied at the end range of passively available range, where the patient will be able to tolerate, and that should be done multiple times. You may not understand. You see this video, then you will understand. So there are 4 procedures. One is supine, other one is ipsilateral side lying, contralateral side lying, and prone lying. See, this is an example of end range overpressure. So this is not capsular stretch. Okay, I'm just pushing the joint to the end range. The capsule will, whatever capsule has to stretch for this movement, it will get stretched. Okay, you don't have to specifically stretch the anterior capsule like how it is given in Caroline Kistner. Don't follow that. You won't get any results. Okay, because I tried it multiple times. Okay, so this is end range overpressure for flexion. If you see this is the end range overpressure I'm doing for external rotation, like this. Okay, once, and then end range overpressure for internal rotation, and then this is for horizontal adduction, and this for horizontal abduction, and I'm doing for external rotation at 90 degrees. See, external rotation in 0 is different. It stretches different part of the capsule. Then external rotation done in 45 degree, it stretches a different part of the capsule. External rotation in 90, it stretches a different part of the capsule. So as with 120. So even external, it's not like you do this, patient will be having full range. No, you have to, every bit of capsule should be stretched at different angles. Then only you will get a global improvement. If not, you will get just one directional or two directional improvement. So this is an example of side lying procedure where just a second. So here is the side lying procedure. Again, I'll do the same thing in short lever abduction, long lever abduction. Here. I think the video is not playing. Okay, then the external rotation done like this is different from the external rotation done like this. Do you understand? External rotation done like this is different from external done like so. Every bit of varieties of external rotation and internal rotation, external rotation with adduction, external rotation with abduction. So many varieties have to be given. So we almost have got 45 variations of the movements. Okay, 45 variations of the movement that has to be done in a given single session, which is about 30 to 40 minutes it will take to finish. This ipsilateral side lying internal rotation and then ipsilateral side lying adduction. So these are the ways by which do we do the movement, and this is a prone lying patient. Have you ever put your patient into prone lying when you treat frozen shoulder patient? Okay, very important because you have to put them into prone lying, because in prone lying, damn, no compensation can happen. See, the frozen shoulder is all about compensation, right? Okay, you ask them to move. See, they move like that. It looks like it's 180 degrees. It's not. The moment you stop them, the trunk from moving, it becomes like 90 degree. Okay, so frozen shoulder is always compensation. So in prone lying, there will be various compensation. This is my patient where I'm doing the prone lying abduction, prone lying internal rotation, prone lying external rotation, hands behind the back. So in prone lying, we have about 14 procedures that we tend to do. It's not a random technique. We have sequenced everything. We have designed, okay, what come first, what next, what come next, what come next. Like that, we have sequenced it. Each movement, each position, what is the angle, how many number of repetitions you do, how to push the end range. So it's all clearly narrated technique that we follow for our frozen shoulder patient. This is called as after protocol. A series of exercises that you do with the emphasis on end range overpressure in all the 4 positions will ensure that the patient will get a global movement. By that, you get improvement in the PROM, and that's the only way you reduce the pain. Frozen shoulder patient, they come to you for pain. But just by giving painkiller, it won't work. You have to get the range. Once you get the range, the capsule will get stretched. Then the vessels and the nerves will calm down. Then the pain reduction will happen. If you directly treat only the pain without treating the range, you will be failing towards the success of the treatment. So treating pain will not reduce the pain. Treating ROM improves the pain. So here are some of my patients who got improved with our after protocol. All waited for about 2-3 months at home, allowed to develop into a full-fledged frozen shoulder. Then they come to us. Okay, here is the patient. He is a diabetic guy. Okay, 6 months old frozen shoulder. Again, you see the improvement in the flexion. And even in the abduction. See, in the abduction, it looks pretty good. You see the internal rotation. Now, if someone says that I did some technique, immediately the range improved. No, I always want them to see how the internal rotation range is. Okay, if you see in the YouTube channels or in the Facebook, people say, see, frozen shoulder, 2 minutes improvement. No frozen shoulder will improve in 2 minutes. If it improves, either it is not frozen shoulder or he is bluffing. He is cheating. Okay. So, frozen shoulder treatment will take time, but definitely with our protocol it improves. And don't forget the biceps. Okay, biceps is also an important thing to be treated. You see the patient, when you do the supinated extension, the patient screams. See? Why? Why? Because biceps also is involved in frozen shoulder. When you do the flexion, you see in frozen shoulder the elbow will be flexed. Why? The biceps is intracapsular. In adhesive capsulitis, biceps also will be involved. One more test is ask the patient to do this. Okay. You see which side is the frozen shoulder here? The right side. Why? Supination is affected. So you also treat the biceps too in frozen shoulder by a separate biceps protocol, aiming for the end range extension of the elbow and with supination. Okay. And coming to the first video, that guy, he is not frozen shoulder patient, he is post-Banquet surgery. Post-Banquets. So we talk about all surgeries. No, at the end of the day, after surgery, they become stiff. Okay, so he came to me after the Banquet surgery, 1.5 months, no improvement. Okay, and then we applied the protocol, then the patient got improved. Okay, so every shoulder patient, say it's a rotator cuff repair, or Lataje, or even Banquets, or whatever, after immobilization, it becomes stiff. So work on the stiffness. Use my protocol. You get the range. Then you think about which muscle to strengthen, which muscle to activate, which muscle to inactivate. And do understand the metabolic component as well. I always talk about metabolic thing. All my patients are here in this picture are all diabetic patients. Okay, talk about diabetes. Talk about glycemic index of each food, because India is dangerously becoming diabetic country. So it will be an added advantage if you talk like that. All right. Last slide. When your patient has shoulder pain along with the neck pain, treat the neck as well. If the neck is not improved, frozen shoulder will never improve. So one clue, patient will have pain here and frozen shoulder pain. In such cases, frozen shoulder will not improve. These are people will go for various doctors without any improvement. These are the hints. All right. So identify early. Medicines are only for short time. Introduce the PROM protocol address the metabolic health, refer to orthos because 85% of the people will improve physio, but 15% of the people will never improve. This is my experience. So that time you refer for surgery, to the orthos who will decide to do surgery or injections. Thank you so much.
Thank you for the talk, sir. Now we will